right, so this is the second part of the OB, and I think I might even have more to cover in this session than I did yesterday. So again, I'm going to go through very quickly, and if I go beyond the 45 minutes, just get up and leave, and this is all being podcasted, so you will have that to review if you want. So anesthesia for C-section, anyone who's already done OB with us knows that generally regional anesthesia is preferred in most situations in order to avoid the increased risk to the pregnant patient of general anesthesia, which includes aspiration, although the aspiration still is a rare complication, but it is higher in the OB population, as well as most definitely the greater risk of difficult intubation in the parturient. So if you're going to use regional, of course, you're going to need like a T4 to T6 level due to the fact that even though it's a low incision that they're in the abdomen. There will be certain patients, though, that cannot have regional anesthesia. That's going to include the coagulopathic patient, probably most commonly those patients with HELP syndrome. If you have a septic patient, or one of the most common reasons we don't do regional is when a patient refuses to have that technique. So if you're going to use regional, then you have to decide which type of regional anesthetic are you going to use. So an epidural, when do you want to use that? Well, I like to use epidurals in cases where I want to make sure I have the safety of a catheter to redose if necessary. So if I think it's going to be a very long surgery, like someone who's 350 pounds and it's her 4th C-section, if I anticipate the patient would have a difficult airway, the reason being that what I don't want is to, in the middle of the case, if I did a spinal, to have to convert to general in someone with a difficult airway. Clearly, if someone's already got an epidural in place for labor, we're going to use that if they go for C-section. And there may be a few situations where you want the ability to slowly raise the level and not have the rapid onset of a sympathectomy. And that would be like in patients with significant cardiac disease. And also sometimes if you have a compromised fetal status, you may not want to precipitate a rapid sympathectomy and a drop in blood pressure that that fetus may not tolerate. So let's go to one of our questions. So which statement about the use of epidural 2-chlorprocaine for cesarean delivery is most likely true? Does anyone want to answer? So the question is actually going to be C. Chlorprocaine is metabolized by plasma cholinesterase. So if you have someone who has a typical plasma cholinesterase, you can see toxicity with the use of epidural 2-chlorprocaine. So if someone says they had a problem with succinylcholine, that they had to stay intubated for several hours after receiving it, well then you probably don't want to use chlorprocaine in that patient either. So in terms of epidural dosing, you want, as I said, a T4 to T6 level. In non-emergent situations, usually lidocaine is our preferred drug. In emergent situations, it's going to be chlorprocaine unless there's a contraindication like we just talked about. Because it gives you that more rapid onset, you can have a block within 2 to 3 minutes, and then the ion trapping issue that we don't have with chlorprocaine that we talked about yesterday. Other things about epidural dosing is that you can have some additives to your local anesthetic. If you add epinephrine to your epidural lidocaine, you'll get an increased density of your block as well as a prolonged duration of your block. And if you want to speed the onset primarily of your lidocaine, this isn't so much the case with chlorprocaine, you can add sodium bicarbonate. Spinal anesthesia is another option whenever you need a rapid onset. So say you have someone who comes in and they're 9 centimeters dilated and they just realize that the baby is breech. So you don't have a lot of time, but you have enough time to do a regional rather than having to go straight to general anesthesia. A spinal anesthetic is a great choice for those sorts of situations. Generally, we prefer to do a spinal or a combined spinal epidural if we have that option, because you do get a denser block than you do with an epidural, and you're much less likely to have issues of, say, sacral sparing that you might see with epidural anesthesia. But a single shot spinal I would avoid in patients, again, where I anticipate a difficult airway or prolonged surgery, because the last thing you want is to do a spinal and then it wears off and the surgeons aren't done and you're now forced to convert to general anesthesia. This was one of the key words specifically that I was asked to address, which is the physiologic effects of spinal anesthesia. So cardiovascular-wise, with spinal, you can see a decrease in your stroke volume. You're generally going to see either a slightly decreased cardiac output or really no significant change in cardiac output. And of course, with that sympathectomy, you're going to see decreased systemic vascular resistance. What about respiratory-wise? Well, in healthy, normal weight women, you really won't see a very significant change with spinal anesthesia. You can see maybe about a 5% decrease in your FVC, and at most a 10% decrease in your peak expiratory flow rate. Those are really the only respiratory changes you should see in a healthy patient. If you have an obese patient, you'll see a larger decrease in vital capacity, maybe as much as 25% in those patients. Now, combined spinal epidural is another technique that you can choose for cesarean delivery. And what's nice about this is that it provides the benefits of spinal anesthesia: rapid onset, denser block, along with the versatility of having an epidural catheter. However, you never know 100% that epidural catheter is going to work, though, until you have actually dosed it. So in most cases, if it's someone that I would consider avoiding spinal anesthesia, I'd also probably avoid a CSE, so such as difficult airway, prolonged surgery. Now, there are times when you do need to do general anesthesia for C-section. It's going to be your anesthetic of choice. If you have a patient who's significantly hemorrhaging, where you don't want to do a sympathectomy in a hemorrhaging patient, or if you have severe fetal distress, like sustained fetal bradycardia, where you need to get the baby delivered as quickly as possible. And of course, pushing drugs and intubating is generally, it's going to be quicker, even in the best of regional anesthesiologists, that's going to be quicker than doing a neuraxial procedure. Your concerns with general are going to be a most failed or difficult intubation, as well as concerns about aspiration. If you're going to do general anesthesia, things that you need to keep in mind is that you need a non-particulate antacid. Even in the status of situations, you should make sure you have a nurse that gets that Bicitra down. Left uterine displacement, you want to make sure that the patient's adequately pre-oxygenated, but luckily, because of the increased minute ventilation, pregnant women will be pre-oxygenated more quickly than a non-pregnant patient. And then, of course, being considered a full stomach rapid sequence induction. So they oftentimes like to ask a question about sort of failed intubation and what are you going to do. So which statement about the management of failed intubation after induction of general anesthesia for an emergent C-section is most likely true? So you have to remember it's emergent, and when you take the test, you have to look at the scenario if you have a failed intubation. So in this case, if mask ventilation is easily achieved, then generally it would be recommended that if the baby's in extremis, that you continue the mask ventilation with cricoid pressure until they can get the baby out. And for those who've done OB, you know that's usually just a couple of minutes in a real stat situation. This would be a different answer if it was someone where you were doing general and the baby was not in extremis. You would consider waking up the patient and then proceeding with either an awake intubation or neuraxial technique. In terms of managing the difficult airway, as I mentioned, if it's an easy mask ventilation and it's an emergency, continue with cricoid until the baby's delivered. Once the baby's delivered, then you need to get the airway secured in a better manner. If it's a difficult mask ventilation and the baby's in extremis, I think most of us would recommend that you place an LMA to be able to ventilate until the baby's out, and then again get a more secure airway. But if it's non-emergent, generally probably the correct answer, if it's your choice on the test, is that you then you awaken the patient and then go with another option for your anesthesia. In terms of maintaining general anesthesia, until baby's delivered, we like to do a 50-50 nitrous oxygen, really doing above 100% oxygen as long as mom is normally oxygenated, doesn't have respiratory disease. You're not going to improve oxygen delivery to the baby, as we mentioned yesterday, if you go above 50%. And then anywhere from a half to 1 mac of a volatile agent. After delivery, as long as mom, again, is oxygenating normally, you can go up on your nitrous oxide because your volatile agents do affect uterine tone, so you're going to want to decrease the amount of volatile agent you're giving. Usually we avoid IV opioids until after delivery of the baby, so there isn't the issue of whether or not baby's going to be depressed by those opioids. But once baby's delivered, then we start adding opioids to our anesthetic. This is another one of those keywords that was obviously covered at some point over the last few years. So what about how does pregnancy affect the uptake of your volatile anesthetics? So the rate of rise of the alveolar concentration of your anesthetic agent in a pregnant patient is going to be increased due to the fact that you have that significant rise in minute ventilation as well as the decreased FRC. Now, if you remember, uptake, what affects it, you probably also remember that increased cardiac output decreases the rise of your alveolar concentration. But the reality is, in a pregnant patient, the combination of the increased minute ventilation, the decreased FRC, is greater than the effect of the increased cardiac output in pregnancy. So, in fact, if you were to do an inhalational induction in a pregnant patient, it would be faster because of that pregnancy. What about effects of general anesthesia on the infant? So what do we know? Nitrous oxide, it readily crosses the placenta, so fetal levels will equilibrate with maternal levels after prolonged exposure. Now, in most cases, if we're doing general, it's stat, and baby's out within a couple minutes. But if you, for some reason, are doing general and it's the 4th C-section and there's lots of scar tissue and it takes a long time to get the baby delivered, those levels will equilibrate. And that's why we try to, before delivery, keep the concentration at 50% to limit fetal exposure. Also, if the induction to delivery time is less than 15 minutes, that you're less, there's going to be less depressant effect. Once you get beyond that 15 minutes, that's when you see more depression of the neonate as those levels have equilibrated. In terms of your halogenated agents, they easily cross the placenta and rapidly equilibrate within the fetus. So generally, it can also result in neonatal depression, but again, not if you get that baby delivered within a couple of minutes. And then the other thing, which probably is not going to be on the in-training exam this year, but to be aware in terms of during the 3rd trimester, the FDA statement about effects of anesthetic agents on brain development, what's mostly been focused on young children, they did choose to include in that FDA statement that prolonged exposure in the 3rd trimester could affect neurocognitive development, so just to be aware of that. Now, what about the effect of your anesthetics on uterine tone? So, if a patient's receiving general with desflurane and nitrous for emergency C-section, which statement about the effects of general on uterine tone is most likely true? So the answer is going to be C. Oxytocin will still work, but it's going to be dependent on the concentration of your volatile agent. Nitrous oxide does not affect uterine tone. And definitely the effect on uterine tone is affected by the pregnant state because there are more oxytocin receptors during pregnancy. So the halogenated agents, they do decrease uterine tone. Desflurane has less of an inhibitory effect than the other agents. So after delivery, we generally will maintain our MAC at 0.5 or less. And as I mentioned, in terms of the effect on the uterus contracting with oxytocin, it's dose dependent. So the uterus will still be responsive if you're using anywhere from 1 to 2 MAC, but less so, not as much of an effect. Once you get to over 2 MAC, you can give all the Pitocin in the world and the uterus is not going to contract down. So it's a dose-dependent effect on uterine tone. Other drugs that can affect uterine tone, ketamine in larger doses, like greater than 1 milligram per kilo, can actually increase uterine tone. And that's something to remember when you're in a situation where you may have uterine hypertonus. Specifically with abruption, you can have uterine hypertonus, a rock-hard uterus. You already have compromised uteroplacental perfusion as a result of the abruption. You probably wouldn't want to use a large dose of ketamine for induction of anesthesia in that case, because that could further compromise uteroplacental perfusion. Another topic that I've been asked in the past to cover is uterine incision to delivery time. So once they start cutting into the uterus, that can result in decreased uteroplacental perfusion, and it's felt that there's an increased risk of neonatal depression if your uterine incision to delivery time is greater than 3 minutes. So that's why we record that on our anesthetic record, so just to be aware of that. Now, we're going to go on to uterine relaxation, retained placenta, another topic I've been asked to cover. So, woman's taken to the OR for maternal extraction of a retained placenta. EBL's 500. Her vital signs are stable. Epidural's been dosed, and she's got a T10 sensory level. And now, as the obstetrician's trying to remove that placenta she requests uterine relaxation. What's the best technique for achieving that? Anyone? Yeah, it's going to be nitroglycerin. Methylorgonervine is going to be the opposite. It's going to increase your tone. Certainly you can get uterine relaxation by a high concentration of a volatile agent after intubating the patient, but that's much more involved, takes longer. And your sensory level of your epidural is not going to affect your uterine tone. So, in terms of methods for uterine relaxation, nitroglycerin is a potent, smooth muscle relaxant, and it is the preferred drug when you need uterine relaxation. It has a rapid onset, but a short duration. If you see hypotension, it's rare that you see it, and it's easily treated and goes away quickly. As I mentioned, you can use, if nitroglycerin doesn't work, then probably your next option is to do a rapid sequence induction, intubate the patient, and then get a level of your volatile very quickly, which would mean turn your concentration high and hyperventilate the patient. Next is preeclampsia. I could spend an hour just talking about it, but anyway, the definition of preeclampsia, as you can see here, systolic pressure of 140 or greater, diastolic 90 or greater, along with proteinuria, or they have changed the definition over the past couple of years. You do not absolutely have to have proteinuria to make the definition of preeclampsia. If you have any of these other things that are listed here in addition to the hypertension, that will give you the diagnosis of preeclampsia. They no longer talk about mild preeclampsia. It's either preeclampsia or preeclampsia with severe features. If you have any of these lists of abnormalities in association with meeting the definition of preeclampsia, then you have preeclampsia with severe features. Eclampsia, in terms of definitions, that's when you have those criteria along with seizures. HELP syndrome stands for hemolysis, elevated liver enzymes, low platelets. That is sort of a unique subset of preeclampsia. In terms of the pathophysiology, the etiology is unclear exactly, but we do know that it involves endothelial damage within the placenta, and as a result of that damage, there's release of placental vasopressor activating substances, and that's why preeclampsia is generally considered a disease of vasoconstriction, and it really can affect any and every organ within the maternal system. We do know in terms of the pathophysiology that there is an imbalance between thromboxane and prostacyclin, increased level of thromboxane compared to prostacyclin, and what that does is that it promotes arteriolar vasoconstriction and also promotes platelet aggregation. We also know in terms of pathophysiology that women with this disease do have increased endothelin levels also, which also has vasoconstrictor effects. So you have an otherwise healthy woman at 33 weeks gestation but has just been diagnosed with preeclampsia with severe features. Which of the following is most likely a sign that she has compromised renal function due to her preeclampsia? So the answer is going to be A, because as we mentioned yesterday, normal creatinine in a pregnant patient is about 0.5 to 0.6. So if you have a preeclamptic and their creatinine's up to 1, they are showing that they have some component of renal dysfunction. In terms of the various effects, the airway, you can have edema with preeclampsia, so you can have more risk of a difficult intubation. Cardiovascular-wise, these patients will have, compared to other normal pregnant patients, increase in SVR, decreased circulating volume. They have an increased sensitivity to vasopressors, so you want to start out with smaller doses of those if you're treating hypotension. In most of these patients, it's actually sort of a high output condition in that you'll see an increase in cardiac output. And the pulmonary edema that you see in these patients is, in the majority of patients, a combination of that increased SVR, leaky capillaries, and fluid overload. It's a small percentage of patients who develop pulmonary edema because they have ventricular dysfunction as a result of the disease. CNS, you can see seizures. The leading cause of cerebral hemorrhage in pregnant patients is preeclampsia. Cerebral edema also can be seen in these patients, along with PRES is seen sometimes in patients with preeclampsia with severe features. You can see renal dysfunction resulting in oligoria. Increased liver enzymes, most common thing with hepatic, but also in severe disease. You can actually have swelling and get subcapsular hematoma and even rarely hepatic rupture. Hematologically, the major thing is thrombocytopenia, but also be aware in preeclampsia, we talked yesterday in terms of physiologic changes, that you have a rightward shift of the oxyhemoglobin dissociation curve. In preeclampsia, it shifts back leftward. And then in terms of the fetal placental unit, there's decreased uteroplacental perfusion. These babies are at higher risk for hypoxia, for IUGR. So a woman presents to L&D at 27 weeks. She's got a headache. Her blood pressure is 185 over 115. She's got big time proteinuria, which is the best medication to treat her hypertension. So B, I heard someone say, yes, magnesium may transiently cause vasodilation, but it is meant to prevent seizures. It's not meant to treat blood pressure in preeclampsia. Lisinopril, the ACE inhibitors, are contraindicated in pregnancy, and beta blockers, as I mentioned yesterday, can cause fetal bradycardia, so we generally avoid those if possible, at least the pure beta blockers. Labetalol is a preferred drug because it is not a pure beta blocker. In terms of obstetric management, the definitive treatment is delivery. The magnesium, as I mentioned, will be used for seizure prophylaxis, and the most commonly used antihypertensives that you'll see are hydralazine and labetalol. So they do like to ask oftentimes on the in-training exam about effects of magnesium in terms of anesthetically. So which statement about the effects of it administering MAG to a patient with preeclampsia is most likely true? D. Okay. So this shows you the therapeutic effects. So one of the things to be aware of is that you can see depressed or absent DTRs at about 10 milliequivalents per liter, and that is one of the main ways that they monitor a patient on MAG. Back in my day, they actually would routinely send magnesium levels. They don't do that anymore, but if they see that the DTRs are gone, then they'll start checking MAG. They'll probably decrease it because you're getting to a level higher than what you want, because you generally want a therapeutic range of about 4 to 6 milliequivalents per liter. Other things that MAG will do, it does increase uterine blood flow, does decrease uterine tone, so these patients are more likely to have problems with uterinatony after delivery, and it does affect your neuromuscular blocking agents. It leads to decreased acetylcholine release and motor end plate sensitivity to acetylcholine, so there's an increased sensitivity to all muscle relaxants, both depolarizing and non-depolarizing. There can be some placental transfer, so these babies could have some respiratory depression. They may be floppy at delivery. In terms of the neuromuscular function, I will mention that if you're inducing general anesthesia, the most important thing is to have good intubating conditions. So it's not recommended with succinylcholine that you decrease the dose that you use for induction, because you want to make sure that you have good conditions, and it's a rapidly metabolized drug, so it's not an issue. Now, if you're going to start giving non-depolarizers to these patients, then after intubation, because you're going to use sucks if it's a rapid sequence unless a contraindication, then you should consider decreasing your dose and seeing how the patient responds when you give non-depolarizers. In terms of anesthetic management of these patients, we like to get epidurals in these patients when they're laboring for a variety of reasons. Biggest one is that, as we mentioned, there may be inadequate uteroplacental perfusion. Babies more likely to have fetal distress and require an emergent C-section. And these patients are at higher risk of general, so you want to avoid that. They're at higher risk of general because they're more likely to have a difficult airway because of edema. Probably the biggest issue, though, is concerns about significant hypertension on laryngoscopy in a preeclamptic patient. So that is the main reason for having an epidural. It's actually been shown, too, in preeclamptic patients, when you place an epidural, your maternal catecholamine levels are decreased, so that may actually help with both blood pressure control, but maybe even more so is that Doppler studies have shown that an epidural in a preeclamptic patient improves uteroplacental perfusion. You do need to be aware, though, that these patients, like anyone else, can have a sympathectomy with the epidural, and the baby may not tolerate that drop in blood pressure as much as a patient who's got a normal non-preeclamptic pregnancy. Now you have a patient with severe preeclampsia going for C-section due to breech. Fetal heart rate's looking fine. Platelet count's 89,000, had been 92,000 24 hours ago. Blood pressure's 152/93. What is most likely true in terms of your anesthetic management? So the answer would actually be C. So, you know, she's got a stable platelet count. You know, you could do neuraxial in this patient. And in terms of the spinal-induced hypotension, although it is a concern, studies have shown spinal-induced hypotension is more common in normal tensive patients than preeclamptic patients. But you want to start treating drops in blood pressure once you've about 20% below your baseline. So you're going to start treating well above a systolic blood pressure of 100. As I mentioned, epidural has often been preferred for C-section, avoiding those risks of general, and also this is a case where you oftentimes do have compromised uteroplacental perfusion. You can more slowly raise the level and avoid any rapid hemodynamic effects. But spinal anesthesia is another good option because you get a block more quickly, and although you may see some hypotension, it's less likely than in a normal tensive patient, and you can quickly treat it if it needs to be treated. There are times, of course, when you'll need general, most commonly because mom has HELLP syndrome, is thrombocytopenic, or severe fetal distress. Things to keep in mind in the preeclamptic patient, especially, is airway may be more difficult than in non-preeclamptics. If you have time, you know, it's not an emergent C-section, you want to consider an arterial line because you can see very rapid rises in blood pressure on induction. And so you should actually consider pre-treatment to prevent that hypertension before laryngoscopy, either with some labetalol, some lidocaine. You could consider a short-acting opioid like remifentanil also. And also have other drugs on hand in case you do have severe hypertension like nitroglycerin or sodium nitroprusside. Now we go on to the bleeding parturient, which is another topic that I could spend an hour talking about. But anyway, you have your antepartum hemorrhage and then your postpartum hemorrhage. So you have a 19-year-old woman, 33 weeks. She's complaining of vaginal bleeding and abdominal pain. The monitor shows she's having tetanic contractions. What's your most likely diagnosis? So that would be abruption. Placenta previa is generally going to be painless vaginal bleeding. Uterine rupture, you can have vaginal bleeding and abdominal pain, but you're not going to have tetanic contractions. And placenta accreta, you're really not going to have significant bleeding from that until after delivery. So we all know what a placenta previa is. Placenta, in terms of management, good IV access, have blood available. Remember that they don't always have them typed and crossed, but this is a patient you may want to have typed and crossed. And your anesthetic technique's really going to depend on your maternal condition. If she's hemorrhaging a lot, she's hypotensive, baby's in distress, you're going to do a general anesthetic and induce with a drug that maintains hemodynamic stability. But certainly if it's a non-urgent scheduled section just because she's breech, just because she has a previa, or if she's just having mild to moderate bleeding, she's hemodynamically stable, it's perfectly reasonable to do a neuraxial anesthetic. Abruption is where you have a normally implanted placenta, but it's prematurely separating. Increased uterine tone, vaginal bleeding, pain, more so than you would expect. Fetal distress, these babies are much more likely to have fetal distress than a mom who's having bleeding from placenta previa. And the one thing to keep in mind is it is the most common cause of DIC in pregnancy is placental abruption. How do we manage these patients? If it's mild or moderate abruption, you have to decide what is the OB's going to do. Oftentimes they'll go ahead and plan for a vaginal delivery as long as baby's not in distress, but still there's always the potential for an abruption to expand and get worse, and all of a sudden she's bleeding more. So good IV access, type and cross. As long as coags are normal, you can go ahead and do neuraxial. If you have a severe abruption, usually that's going to require an emergent section because either mom is unstable or baby is in distress. And so usually you're going to require general anesthesia as a result of that. What is the most common sign of uterine rupture during VBAC attempt? This has been a question in the past. So the answer is fetal bradycardia. It's actually abnormal fetal heart tones. These other signs and symptoms you can see, but the most common is fetal bradycardia. Anyone who has had a prior uterine scar is going to be at risk, and the signs are primarily those that you would expect in terms of bleeding as well as affecting the fetus. Again, generally, treatment is like any other hemorrhaging situation, access, blood available, but do remember that you may have a more stimulating surgery because they have to either fix that uterus that has ruptured, or if it's a bad rupture, they may actually have to do a hysterectomy, and the patient may not tolerate that under regional, but you can, as long as mom's stable, you can do a uterine rupture case under neuraxial. You have a woman who's a gravida-4 pair 3 with a placenta previa. She presents for C-section. Doesn't have any recent vaginal bleeding, normal blood pressure, vital signs. Pre-op crit's good. She's had 2 prior C-sections. So what is your management going to most likely include in this patient? So the key here is, and we mentioned this in Journal Club last week, she's got a placenta previa and she's had 2 prior C-sections. That is a red flag that she is at risk for abnormal implantation of the placenta accreta, increta, or percreta. So she can have major bleeding, so you want to have blood available for this patient. So placenta accreta is where the placenta is abnormally adherent to the myometrium. And if you try to separate that placenta, you can get massive hemorrhage. So if you make the diagnosis ahead of time, generally they will not try to deliver the placenta. They will close up and do a hysterectomy. And these patients just need to be treated like a big-time case for potential massive hemorrhage. Now, postpartum hemorrhage. Most common cause of postpartum hemorrhage is uterine atony. Risk factors, a variety of risk factors, just need to sort of have that in your head. But the reality is that although there are risk factors, the majority of women with postpartum hemorrhage with uterine atony actually don't have any of those risk factors. So there's a lot of patients you can't predict that they're going to have it. So generally one of the first treatments for that is going to be pharmacologic. So you have a woman with asthma, postpartum hemorrhage with atony, blood loss is now 500, she's still bleeding. They've done uterine massage, which is your first treatment. She's hypertensive. So what are you going to do in this patient? What's your first line drug? So it's going to be oxytocin, and remember that she's got asthma, so you probably want to avoid hemabate. She's got hypertension, you want to avoid methergin, so it's a bit of a conundrum there. You have another healthy woman who's just gotten 20 units of Pitocin, but the person's new to OB and forgot that you don't give it as an IV bolus. So which of the following is the most likely adverse effect of that 20-unit bolus of oxytocin? And it's going to be hypotension because it does cause vasodilation, and especially if you give it as a bolus. So as I said, first line treatment for atony is pharmacology. So oxytocin is your first line drug. Next is methergin. It can cause hypertension. It should always be given IM. You don't administer it IV because that can cause severe vasoconstriction. And you avoid methergin in hypertensive patients. And hemabate, most common concern is bronchospasm. It's relatively contraindicated in patients with asthma. You can see some mild hypertension with hemabate, but it wouldn't lead me to generally avoid it in most patients. Other than that, if that doesn't work, then you need to be thinking about making sure that you've got good access, you've got blood. The next thing that they commonly do is uterine tamponade with a Bakri balloon. If that doesn't work, then you may end up having to go to a general anesthetic for an invasive procedure that can go all the way up to a hysterectomy. And then also, if, as we talked about last week, TXA if everything else hasn't worked. In terms of, I was asked to talk about the management of intrapartum fever. So your treatment is to lower maternal temperature Try to identify the cause of fever. So your management's really going to be based on the etiology. If they've got chorea, you're going to treat with antibiotics. If it's an epidural-related fever, we know that it's not infectious. There may be inflammation involved in that fever, but it's not infectious, so you're not going to treat with antibiotics. Amniotic fluid embolism, rare but often fatal. To have an amniotic fluid embolism, there has to be rupture of amniotic membranes, and there has to be some site of entry into the maternal circulation. So during labor, as you know, there's some little vaginal tears, whatever, there's definitely a place for there to be entry. Signs and symptoms, just all of a sudden short of breath, drop their sat, get hypotensive, cardiovascular collapse. Once they get past that initial acute event, over time, they can also develop DIC and left ventricular failure. Pathophysiology, it's not an actual mechanical obstruction. What happens is that amniotic fluid gets into the pulmonary circulation, causes an intense vasospasm that then leads to your cardiovascular collapse. And about 40% will have DIC. These patients also, on top of everything else, have a higher risk of uterine atony. Management is really, it's supportive. Get the patient intubated, ventilated. They oftentimes will need inotropic support. You may have to deal with DIC also. Now cardiac, that's my next one. So patient with mitral stenosis gets hypotensive with induction of your epidural for C-section. What's the best drug to treat her hypotension? So the answer is going to be phenylephrine, because all the others can cause tachycardia, and that's a no-no with these stenotic problems. So you can just quickly look at this. You know, just if you understand the pathophysiology of the various stenotic and regurgitant lesions, you'll know how to manage them in the pregnant patient. But with mitral stenosis, you want to maintain sinus rhythm, relatively slow heart rate, maintain SVR and venous return. Pregnancy actually is beneficial in patients with regurgitant lesions because of the decrease in SVR. It helps with forward flow, so patients usually do better with this. But again, you need to have sinus rhythm. In these cases, you want either normal or slightly higher heart rate. You do need to maintain venous return in these patients also. Aortic stenosis, very similar to mitral stenosis, and aortic regurg, similar to mitral regurg. Cardiac dysrhythmias in pregnancy. Women who are pregnant have a higher risk of cardiac dysrhythmias than non-pregnant women, and SVT is most common. Most antiarrhythmic drugs can be given safely in pregnancy, including adenosine. Amiodarone, though, can be associated with adverse fetal effects, so you should only use it if you have a refractory dysrhythmia that's not responsive to anything else. Another thing to be aware of, cardioversion, and in the setting of VTAC or VFib, defibrillation is safe in pregnancy. You use the same energy levels as in a non-pregnant patient. The current reaching the fetus is going to be minimal. If you're doing a cardioversion, though, you may see some transient fetal heart rate abnormalities, so fetal heart rate monitoring is recommended if possible. Congenital heart disease is now the most common form of heart disease we see in pregnant women. The cardiovascular changes of pregnancy can lead to a return or an increase of symptoms in patients who have been doing quite well after surgery. You need to fully understand the patient's pathophysiology, their anatomy, and have a multidisciplinary approach to these patients. Pulmonary hypertension was another topic. So which statement about pulmonary hypertension in pregnancy is most likely true? And that would be that you can use nitric oxide in these patients. The drugs you use for treating pulmonary hypertension, you can use in these pregnant patients. There's a high maternal mortality. You don't like to see the combination of pulmonary hypertension and pregnancy. Generally, unless there's an obstetric reason for C-section, vaginal delivery is going to be preferred. Labor analgesia is beneficial. Invasive monitors are generally going to be needed. And as I mentioned, you can use pulmonary vasodilators, including nitric oxide, although be aware that there is, at a high concentration of nitric oxide, the potential for fetal methemoglobinemia. Most of these women, if they do not survive, it's usually problems in actually the postpartum period. That is a key time. Cardiac arrest in pregnancy. You follow your usual ACLS protocol, essentially. You don't do anything different. The only thing you do different is that you make sure someone has the role of manual left uterine displacement, because your CPR will not be as effective if you don't have that left uterine displacement. But if you turn them too far on the side, your chest compressions will not be very effective either. So the best thing to do is someone just stands there and pushes the uterus to the side rather than fully tilting the patient. And the teaching is, if at 4 minutes you're not successful in your resuscitation and this is a viable fetus, you immediately deliver that baby, because obviously outcome for baby was better, but also when you release that aortocaval compression, the mother's success. There have been several cases of where as soon as they get baby delivered, mother comes back. This was another topic that I guess was on there a year or two ago that I was supposed to talk about. So antiphospholipid syndrome. It's a prothrombotic disorder that you will see with either anticardiolipin antibody or lupus anticoagulant. These patients are at risk for VTE, with nearly 25% of events of VTE occurring in people with this disorder when they are pregnant. They also have an increased risk of fetal loss, especially during the second and third trimester. The other thing to keep in mind is the lupus anticoagulant. It's a sort of a misnomer. It does not have any anticoagulant activity. It does result in a prolonged PTT, but that's like a lab artifact. So if you know they have the antiphospholipid syndrome, they have a prolonged PTT, everything else is normal, you can do neuraxial anesthesia in those patients. And I guess I'm done. So I got done in less than 45 minutes again. All right, thank you, everyone.